it's a great honor to be here in front of family. So this is a very commonly encountered subset which is asked in both theory and result as well as practicals. So the idea is just anyone can volunteer and pick up the case forward. We can discuss it with all our teachers here. That was the idea of this talk. And picking up from where I think Sir was mentioning in the last case about the Harki formula, this is the same thing. So it's just a very broad thing which you're saying. So let's take for example a 70-year-old man. It's not hypothetical. He has class 2 symptoms. He is diabetic, hypertensive. He has nephropathy on the obese side, and he has severe erectile dysfunction. It is a very thin calcific wall. A gradient which echo-wise, despite lot of trouble, is only given to what is a moderate mean gradient of 36. PP is 96 by 60. So this is again a very common subset. This was one of my long questions in my exam also. How will you evaluate this condition dash? So how will you evaluate this is all that is. How will you evaluate such a patient is all we are interested in. If anybody can volunteer. Yeah, we can discuss it with all our teachers. I have a couple of slides from showing the guidelines, nothing more than that. So if someone can just volunteer and start with that.
How would you evaluate this patient next? Anyone can. How is 71-year-old?
He's a 70-year-old
with this
multiple comorbidities, and this is hypothetical echo. How will you go forward and evaluate?
He has exertional angina and dyspnea with significant risk factors. We need to rule out coronary artery disease also.
Right, agreed. So how will you evaluate next about, yes, we have to do an angiogram anyway, but what about the wall? That is the main idea. We are looking at a moderate gradient with severe LV dysfunction. So what we call a low gradient, low flow. That is the topic of discussion. So if anyone can come forward and go and discuss it, we'll just take a few slides on the appropriate guidelines which we encountered. Which is what we have to write in our exam. It's a commonly asked long question as well, isn't it? As well as in the practical. How will you evaluate this subset? That is what is.
What would you do next?
Yes.
Can I have one person answering that? In the DAC, what do you want to see? Please stand up. Doesn't matter. Doesn't matter if you're wrong. No, exactly in the DAC, what do you want to see? Objectively, what do you want to see? What do you see? No, give him all.
Yes, sir.
So why to do double station?
Do you want to do a DAC at all with an angina? That's the question.
Angina patient you have DAC, you have not I can touch. So you have to expect coronary disease.
Yes, sir.
So what do you do on progress CT angiogram and CT of the heart? Yes.
Mean gradient of the 35.
Patient has CKD stage 3, that's why we put it. So we can't give him contrast.
It's just for discussion.
Plain.
It's just for discussion how we take. So before we go into further things, this is a very common thing which is slight from longer.
So was seeing CT. So is there a point at which you say calcific layer? That was also the point.
No,
Since you can't give contrast.
sir, what I'm explaining sir, he has got angina pectoris, dysfunction. You rule out coronary disease.
Yes, sir.
You rule out coronary
Yes,
disease.
sir.
There is no coronary disease, then you do coronary.
And in fact, adding on to what Dashwar is saying, there is one more advantage of a CT here, where apart from coronary disease, we can also take CT for calcium on the wall. That's what
Only that score of say 2000 whatever. Only concern that he has disability. So security how much speed is that?
It's a great piece, sir. Class
That way your reduction won't go to coronary. So you have another one. No coronary disease. You can do whatever it is low target or it is high low whatever.
Sir, why not the conventional angiogram directly? Why CT first? Because we have already LV dysfunction. And
Second time same thing, the link to coronary angiogram. CT angiogram, reduce won't do. Yes, if it is, I won't do CT angiogram.
They won't give contrast, so this seems through conventional.
Yes, sir.
Conventional 5 ml is in regular coronary disease. Then if you cannot do it, double station, go on CT of the abdomen.
So same way
Gradient of, the mean gradient of 35 in the presence of severe elbow dysfunction with the EF of 25% is significant. It's not really low flow, low gradient. It is significant gradient in the presence of severe elbow dysfunction.
It's underestimated.
Underestimated, yes. It's not truly called as it
No,
doesn't fall as a
only thing that is
category.
only that we are doing to comprehensive co-curriculum. If you want to computer, see the outdoor area.
Yes. 2D area. If it's not
If the
2D,
outdoor area is less,
yes.
then only 12.
And the cardiac output will be low in this patient. So with the low cardiac output, the mean gradient of 35 is significant.
So it's just that again, this is commonly frequently asked in the exam, so we should know all the classes of AS, and what is pertinent for us is what are class 1 indications for AVR. So in that sense, any class D and C2 are class 1 indications for AVR. That is what we have to remember. And in the D, we have the standard D1, then D2 is what we are talking about now, and then D3 is the paradoxical local locator. Point to remember is that LV dysfunction in AS is 50%, isn't it? As compared to AR, which is 55% the cutoff, and for mitral valve, which is 60%, which is an important cutoff. And for normal subjects, is 50%. So I'm just going to be taking a few algorithms from this very good article, which I also use for my exams, for what will be right in terms of low gradient case. So when we have a low gradient case, we will first divide it into whether classical low flow low gradient, and then is it only a low gradient case? Then subtypes based on low flow. So flow we decide based on stroke volume index. So we have the classical low flow low gradient, and we have the paradoxical low flow low gradient, and then we have the normal flow but low gradient case. These are the types. So how do we evaluate a low flow low gradient case is what we were looking at, and of course this case is just hypothetical, just to take discussion forward with all our teachers. But yes, the idea of doing dobutamine stress echo, we have to look at two things in that. First is increase in gradient. We have to prove it. Unfortunately, textbook wise, we have to show a gradient of 40 if we want to subject the patient for area. So that is the idea of BSc is one, gradient, and two, contractile reserve. So this concept of contractile reserve is often asked in the exams, and I was also asked in my exam, would you operate a patient without contractile reserve? And of course I gave the wrong answer and I gave the prize for it. So again, if you do DSC, first thing is if your gradient goes above 40 mil gradient, it's true severe AS. Then we go through the pathways of management of towers. If it is equivocal, that is the problem. So the gradient doesn't rise, fine. But if we have something equivocal or we cannot do, then CT calcium scoring is very important. So for males the cutoff is 2000 and for females the cutoff is 1200. If that cutoff happens, then yes, it is probably true severe AS. I'll skip this one for now. These are some of the main poor prognostic risk factors for which have been shown for low flow low gradient. Like irrespective of even if you manage a patient medically or you do AVR, if they have these prognostic factors, their outcomes are bad in any way. So this includes a lack of contractile reserve, but I'll come to the importance of contractile reserve now. So DSC में the thing which we are looking for is a rise in contractile reserve by 20% or a rise in stroke volume by 20%. That is good contractile reserve. So what we are expected to say, and this has come through in many data, is that long term both subsets do the same. So whether you have a low contractile reserve or a good contractile reserve, on a long term basis they do the same. But the peri of mortality of a patient with a poor or bad contractile reserve is to the tune of 25-30%. That is what we have to explain to the relative. If you are willing to take or wager that poor peri of mortality, the long term prognosis is the same. So this is what we are looking at in terms of when someone asks us about low gradient and the importance of contractile reserve. I will just skip through these slides fast. This is the same thing which I just discussed. Who are class 1 indications for AVR? They are any stage D and class C2. In asymptomatic severe AS, you have some categories where you have raised BNP or they call very severe AS or gradient more than 60, then they are class 2 indications. Why this is important for us is in the guidelines, the 2020 guidelines which we are expected to write in the exams, patient who is to be taken for tower are all only who fit a class 1 indication for AVR. So you don't take at least till now, things are changing because of so many trials, but someone who has a pure 2D indication does not go for a tower. Anyone who is only a class 1 indication for AVR can go for tower. So this is the same thing again. This is also from Robert. Anyone who requires, who is a fit candidate for metallic walls will never be subjected for a tower, whatever the end function. More than 65 is again the caveat. So between the age of 65 to 80, they say it's a shared heart team approach, where it's a decision between the doctor and the heart team. Age more than 80, they are class 1 for tower, and tower they are class 2B, which is the same thing. That's all I wanted to discuss.
In actually one of the exams 2 years back, the earlier flowchart we had put to actually go back. So this was shown with empty boxes. No, the second last. This was shown with empty boxes and A, B, C, and that had to be filled by the candidate. Some of these boxes were empty. Which class of recommendation? This was asked in one of the exams.
So you need to know that flow diagrams of AS, AR, NS, MR, in photo, which has to be printed in your brain before the exam. You have to write it. There's no way out. Multi-message disease, whatever it is, they go for area which will cover the disease. There's no way out. For multi-message disease, mandating coverage. But there are some data saying, can we do tower and PCA? Again, there are some Cochrane reviews which say that tower plus PCA still has more risk of mortality and stroke as compared to a tower with coverage.
Patient is sick, cannot wait and
Then we can if the patient has severe DVD mandating coverage, there is no way out. He goes for a high risk coverage failure. Whatever it is, they have to accept.
Thank you, Subramanian. Thank you. We were waiting for AS with low EF. We didn't get a patient. We thought we'll keep a hypothetical patient. We have come to the end of today's proceedings. Thank you all for staying back. Very happy to see a full hall actually. Nobody is left even after the replay. We start early tomorrow morning. Tomorrow we'll continue. We'll have more faculty joining. Dr. Patnaik joins us. Dr. Ramakrishnan sir joins us. Dr. Gopi joins us. And we'll have all our faculty volunteer today as well. We'll also have the sessions tomorrow. We start at 8:30 and those who have not taken the cases yet, please contact us. We'll give you the cases now. I thank all the faculty for staying back and request all of you to join us again tomorrow. Thank you so much. Sign off.